Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
My name is Dr. Kara Thomas, and I am a physical medicine and rehabilitation doctor. I wanted to take a little time to share a little bit about my field, let you guys go through a typical day in my life, and to go over a few common cases that you tend to see on the acute inpatient rehabilitation unit. So hope you enjoy. So physical medicine and rehabilitation is also known as physiatry. Not psychiatry, not physical therapy, but physiatry. PM&R, we've got a lot of names to the field. PM&R is basically a field that focuses on restoring functionality for patients and improving their quality of life after any kind of physical impairment or disability, whether that be developmental, whether that be something like a traumatic brain injury or spinal cord injury, or different types of musculoskeletal type problems. Our main goal is to prevent, diagnose, and treat disorders that may produce temporary or permanent impairment. So we focus on the functionality aspect of it. We really focus on patient-centered care and integrated care with a multidisciplinary team. We try as much as we can to have patients avoid surgery, and that seems to appeal to a lot of patients. Sometimes surgery is inevitable, but if we can sort of find other options prior to surgery that may work for the patient, that's really what the focus is about. And we combine both pharmacological and non-pharmacological modalities. And so we, as physiatrists, coordinate and lead interdisciplinary treatment teams. And we've got great staff. So physical therapists, occupational therapists, neuropsychologists, speech pathologists, recreational therapists, case management, and nursing staff. So we all work together to come up with a plan for the patient and basically sort of see the treatment plan from start to finish, from the time the patient is admitted to the time that they're discharged. And my colleagues all work in very different settings. I work in an inpatient setting, and many of my colleagues either do outpatient or a combination of the two, or really focus more on procedural type. They're in the operating room with the fluoroscopy machine, really working on a lot of different procedures. So it's a pretty vast field. So people often ask, okay, so what kind of conditions do you treat? You sound a little bit like neurology, you sound a little bit like orthopedic surgery, you sound a little bit like pediatrics. So again, it's a pretty broad field, but you can kind of categorize the conditions that we see in different categories, such as musculoskeletal. So we may treat, if you're a sports medicine doctor or a sports and spine doctor, you may treat sports-related injuries on the college level, on the professional level, or just sort of your everyday Joe who comes in with things like back pain, neck pain, knee pain, carpal tunnel. We see patients after they've had reconstructive surgery or knee replacements, hip replacements, amputations from things like vascular disease or diabetes. So we kind of help them get back to function as much as they can. In terms of the neurological aspect, we see a lot of patients with spinal cord injury. That's actually my specialty. But then you can also see patients who have had traumatic brain injuries from car accidents, strokes, other types of movement disorders, multiple sclerosis. And we also see patients who've been debilitated. So patients who may have undergone a CABG or a bypass surgery for their heart, or who suffer from COPD. And most recently, people who've had COVID, who've been in the ICU or in the hospital for a really long time and have a lot of myopathies and muscle issues and are just very, very debilitated after being in the hospital for a long time. So we're starting to see more of those patients. And there's also cancer and pediatric patients that we see as well. So in terms of the training for PM&R, so in general, there's 4 years of medical school. That's pretty standard for everybody. But residency really consists of 1 year of internal medicine, a prelim year. So either internal medicine, you can do surgical, or you can do a transitional year. Now, some programs actually have a categorical program, so it's kind of built into the same system. But for the most part, you're doing a 1 year prelim in a sort of more general area. And then after that, you're going to complete 3 years of PM&R training. If you decide to, so after that, you can practice, but a lot of people decide they want to do a fellowship to further specialize or subspecialize. And so our fellowship programs are typically 1 to 2 years. I personally did a spinal cord injury fellowship, which was 1 year. But there are a lot of different areas, and everybody has different interests. So you can do interventional pain management, which is something that's either a PM&R program, a family medicine program, and some anesthesia programs actually accept PM&R students. You can do sports medicine, which might be sort of get into that emergency medicine programs as well as family medicine. But a lot of people really love sports medicine as well. There's brain injury. There's sports and spine, which is a combination of sports medicine and the interventional pain. You can do pediatric rehab and deal with patients who have developmental issues, cerebral palsy, things like that. You can also go into some non-accredited programs like cancer rehab and multiple sclerosis, or you can sort of, go another route and do like hospice and palliative care. So quite a few options for people based on their interests. So in terms of my day-to-day life, I do mostly inpatient. So I will get to the hospital and I have a service of patients. So I will round on my different patients. I like, for the most part, to see them during their physical therapy or occupational therapy. It gives me an idea of what their functional status is and allows me to really communicate with the therapist on what the update is, if they're having any pain, if they're having any change in their functional status. So I tend to see patients when they're in the gym and talk with them and round. I have interdisciplinary team meetings with the group of people that I talked about earlier, just to kind of discuss care plans for patients. I talk to families. A lot of times we like to have families come in and do rehab or kind of witness rehab with their their family members, just to do family training, sort of to better prepare them to go home. So it's really interesting. I will admit patients to the hospital, either from the acute hospital or sometimes even from home if they're having a change in function. Other parts of the hospital, other services, whether it's ortho, trauma, internal medicine, often we'll put in consultations for, pain management, or if someone has a spinal cord injury, there might be some neuropathic issues or nerve pain issues that they have, and really just trying to see what we can do to get them over to the acute inpatient rehab side so that they can have intense therapy. And I don't currently do this, but a lot of my colleagues will also see patients in outpatient. So patients either discharged from the hospital, they will follow up and do sort of chronic pain management, or, we'll talk about bowel or bladder issues or any kind of pain related issues. So a lot of different options. All right, so I wanted to share A pretty common case that we learn about in residency and that I saw a lot of as a spinal cord injury fellow. It is a spinal cord injury case. So the patient is a 23-year-old male with a history of a cervical 6 complete spinal cord injury due to a history of multiple gunshot wounds. This patient presents to your office for follow-up after discharge from an acute inpatient rehabilitation stay with the following symptoms. The patient complains of pounding headaches, sweating, blurry vision, and increased spasticity in the lower extremities. So increased tone in the lower extremities. What is your differential diagnosis? So some of the things that I think about with this, you can sort of go through the different symptoms. Someone comes to you with a pounding headache. It could just be a migraine headache. It could be something pretty benign. Or you could think it may be something more serious in terms of a bleed in the brain. For sweating, it could be some sort of infection. For blurry vision, I mean, this patient's young, but could be a stroke. And for increased spasticity in the lower extremities, sometimes with spinal cord injuries, you may think of sort of fluid collection around the spine. So that may be some consideration in terms of this presentation. However, these symptoms are classic of what we call autonomic dysreflexia, which is pretty specific to spinal cord injury patients. Next slide. So what is autonomic dysreflexia? So basically, it happens for the most part in patients who have a spinal cord injury at the thoracic 6 level or above. It's basically an imbalance of the sympathetic discharges that a patient experiences. It's really a medical emergency. So recognizing and treating the early symptoms of it is really important to prevent, very serious complications like death or a brain bleed or a stroke. So some of the signs and symptoms of autonomic dysreflexia is some of what we talked about in the case, but you may see a patient who is very hypertensive. And when I say hypertensive, it's a little bit tricky because I don't necessarily mean that their systolic blood pressure is like 200. Spinal cord injury patients typically have low blood pressures. It kind of runs around, 90, 100 systolic, so the upper number. So as long as the patient, and spinal cord injury patients tend to know what their baseline is, it tends to be pretty low. So if the systolic blood pressure is about 15 to 20 millimeters of mercury above their average, that may be hypertensive for them. So if their normal is 100, if they're presenting to you at 120, 130, you may not think anything of it, but for them, that's actually very high. So other signs that you may see would be a low heart rate or bradycardia. You may see kind of hair sticking up on their arms, sort of pallor of the skin. You may see bladder spasms, sweating, again, a pounding headache, and nasal congestion. And actually the presentation of this is pretty dramatic when you see it, because you're kind of wondering what's going on with this patient. So those are typical things to look for. So basically what causes this is any kind of noxious stimuli below the level of the injury. And when I say noxious stimuli, I mean anything irritating. So it could be a full bladder, it could be a full bowel, it could be a pressure ulcer, it could be, honestly, I've seen a patient who had a pen that he didn't know he dropped in the bed, and it was sticking into his thigh. And, he couldn't feel it, he didn't know, but it was causing him symptoms. And so you really have to do kind of this head to toe analysis of what's going on with the patient. It could be an infection, it could be kidney stones, it really could be just about anything. So you really kind of have to think about what's going on with the patient. So basically, it occurs because of a noxious stimuli below the level of the injury, so below T6. So most common being a full bladder. That's actually the most common cause. It sends a signal from the bladder, sort of to the spinal cord, and it basically gives this sort of massive sympathetic response. And so the body is responding as it normally should. It says, okay, something's going on. let's vasoconstrict the blood vessels, and this leads to high blood pressure. And this signals to the brain, like, hey, brain, like something's going on here. Let's try and slow this blood pressure or decrease this blood pressure. And so basically it sends a signal to the brain and the baroreceptors to slow down the heart rate. That's why you see patients with low heart rate or bradycardia. And basically, because there is a blockage with the spinal cord injury, this sort of like inhibitory signal is not getting through completely or is completely blocked. So basically, anytime a patient has any kind of irritating, stimulus below the level of the injury, it basically causes these symptoms. And so it's very striking presentation, and it's definitely something that you have to treat very quickly. Spinal cord injury patients are a little bit rare. So if you just happen to be, Dan, if you just happen to be rounding, in the hospital and you see a spinal cord injury patient, you may not run across that many of them. But if you see this presentation, you should definitely think about, well, they've got a high level injury. This may be something abnormal for them. Even if I'm seeing a blood pressure of 120, which usually doesn't excite too many people, but for them, it is an emergency.
Right. So. Interesting.
Okay, this is just basically sort of reiterating what the picture said before. So I guess we can skip that.
Okay.
So in terms of the management for autonomic dysreflexia, the most important thing we're going to do is we're going to make sure that we're checking blood pressure. And really, if someone's having an episode, you need to be checking the blood pressure every 2 minutes until it resolves. So like I said before, an elevated blood pressure for spinal cord injury patients isn't necessarily 190 or 200. It may even be 110 or 120. So you just have to make sure that you're kind of aware of what their baseline is. So if they have an elevation above 15 to 20 millimeters of mercury above their normal systolic blood pressure, that may be elevated for them. And I feel like spinal cord injury patients really tend to know their bodies pretty well because it's a chronic condition. So they'll tell you, like, I'm normally 90, or I'm usually systolic 100 blood pressure. This isn't normal for me. So the first thing that you do for the patients, you try and keep it simple at first. You make sure that you sit the patient up in the bed. You loosen any restrictive clothing. So if they have any compression stockings on, if they have any tight fitting clothes, make sure you take that off. The most common source of autonomic dysreflexia is the urine. So a lot of these patients either have Foley catheters in place, so you need to make sure that it's not kinked or, coiled in some way. Some of these patients aren't able to urinate on their own, so they may be getting straight catheterizations periodically as part of their treatment plan. So if they have it, you can bladder scan them. You can make sure that you catheterize them to get the urine out. That usually will bring down the blood pressure. So you try these kind of simple things first. If you feel like the patient hasn't had a bowel movement in a while, you may need to disimpact them. That may be a cause and maybe a solution for bringing down the blood pressure. If that doesn't work, then you can kind of turn to some of the pharmacological agents. You can put nitro paste on the chest, about a ½ inch of it, and sort of recheck the blood pressure. And a lot of times that will bring the blood pressure down. But the most important thing is to make sure that you're treating the underlying issue, because it's something, whether it's an infection of the bladder or whether it's, their bladder's too full and it's just causing them discomfort, but because they can't really feel it and probably can't tell you, exactly what's going on. It may be something that's just kind of sort of under the surface that you just kind of have to be a detective about. All right, so this is another case that was actually pretty common, at least in the residency that I did. I saw quite a few of these cases, and actually on the spinal cord injury unit as well. But this is an example of a 74-year-old male who has atrial fibrillation and was on an anticoagulant like Eliquis or warfarin. And this patient fell at home. They were transferred to the emergency room and found to have a subdural hematoma, so a bleeding in the brain that required evacuation by neurosurgery. The patient, after surgery, was medically stable and transferred to an acute inpatient rehab facility for further rehab of things like speech, mobility, and activities of daily living deficits. About 2 weeks into his stay, the patient develops redness, pain, fever, swelling, and decreased range of motion in his left knee. When people see this, the sort of musculoskeletal sports medicine side comes out, and you start to sort of go down the list of differentials. So, does he have a septic joint? Is his knee infected? Does he have a deep vein thrombosis? Does he have a clot in his leg? If he's having swelling, maybe it's a cellulitis. Could be a hematoma, maybe that was formed, basically a bleeding sort of in the leg there. So there's a lot of different issues that could be going on with him. So, but one of the key things to think about, and you definitely have to sort of do that workup, but one of the key things to think about is that he is a traumatic brain injury patient. So he's at higher risk for something that we like to call heterotopic ossification, or HO. So HO, I feel like is like orthopedic surgery's worst nightmare. It's very difficult to treat. It's basically a formation of lamellar bone, mature lamellar bone, in soft tissue. So basically you're getting bone formation outside of where it should be forming. So you may get it sort of to the side of the knee, outside of the patella, outside of the ligaments and the cartilage there. So basically, HO forms between muscle planes. You get an ossification, which is basically the process of creating bone or transforming cartilage into bone. So this is actually very commonly seen in the type of patients that physiatrists take care of on the inpatient side. So traumatic brain injuries, burn patients are huge. They get this all the time. Spinal cord injury, stroke patients. And it can also happen after a patient's had an orthopedic surgery. So some orthopedic surgeons will actually prophylactically treat this. And I'll talk about that a little bit later, but they'll actually sort of prophylactically treat their patients knowing that they may form HO after a surgery. So something to think about. But it occurs in about 20% of patients where they have some loss of range of motion, and a very smaller amount have very severe functional limitations from HO. So in terms of the pathophysiology and etiology of it, we don't know exactly what causes it. They think that it just really has to do with an inflammatory process that occurs after some sort of stressful event with increased blood flow to the soft tissues. So you have these local systemic hormonal factors that are kind of contributing to the formation of this bone outside of areas that it really shouldn't be. And so it's kind of laid down, and it really takes a while to mature to become fully hard and almost completely bone-like. So 6 to 18 months. But you may start to see symptoms anywhere from 4 to 12 weeks following any kind of injury, like we talked about, a stroke, a brain injury, spinal cord injury, or after a surgery, like a hip replacement or knee replacement. It's definitely one of those things your mind kind of goes to other things, like you start to think it's an infected joint, or something a little more, common that you might see on the outpatient side, but definitely in patients who've been through any kind of trauma, whether that be surgical induced or, sort of on their own, definitely something to keep in mind. Okay, next slide. Okay, so some of the most common areas for HO, especially in this case, which is a brain injury patient, sort of depending on your injury, it may sort of change where the most common site of injury or where the most common site of HO occurs. But for a brain injury patient, the most common site is the hip. So they may complain of, swelling or pain in that hip. The next one would be their elbows and shoulders. And then following that, you may see it in the knees as well. So, and there's actually a correlation between how severe the HO is and how severe the brain injury is. And again, that just may be just all the inflammatory factors and sort of the recovery, the stress of the body. Okay, so how do you diagnose HO? So the most sensitive test and the best test to really detect this early is to get a three-phase triple bone phase scan. A three-phase bone scan. So basically, this helps to sort of rule this in early on. This can be detected about 4 weeks earlier than a plain X-ray. So a lot of times people will say, okay, you've got something going on with your knee, let's get an X-ray. But if it's too early in the process, the X-ray may not show anything. So I definitely understand X-rays are probably first line for what you might think in terms of ruling out other pathologies, but definitely keep in mind that a bone scan is really going to be your most sensitive and important test. So if it's past that sort of 4-week mark and you're a little bit later on in the process, an X-ray may show the lamellar bone formation. Another thing that you can do if you kind of want to help rule it in is to get a blood test and look for alkaline phosphatase in the blood. This is a marker of the osteoblastic and osteogenic activity that increases with bone deposition. Now, it's not specific at all. It really doesn't, pinpoint it. It's exactly HO because it could be a lot of different things, but it's just one more thing to sort of put the case together. Okay, so how do you treat HO? So I will say it's not necessarily an easy disease to treat. One of the things that we start off with is etidronate, which is a bisphosphonate, kind of what you would use for osteoporosis. And you just use high levels of that medication. So basically, this drug basically inhibits the conversion of calcium phosphate to these hydroxyapatite crystals and prevents mineralization of the bone matrix. So again, if you do this too early, or do it too early, you're not going to see it on X-ray. A bone scan would be your test of choice. But basically what we do for patients is we put them on 20 milligrams per kilogram of etidronate for 2 weeks. And then we follow up by 10 milligrams per kilogram for 10 weeks following it. So it's a long treatment for this. Some of the things that you can do to help prevent it, and a lot of orthopedic surgeons will sometimes recommend radiation therapy for their patients prior to getting hip surgery or knee surgery, just because they, like I said, they really hate and loathe HO because it's a very complicated, and it just kind of messes up the patient's functionality and range of motion. So if they're agreeable, sometimes radiation therapy before a hip replacement or knee replacement may be preferable. Sometimes warfarin can help. I don't quite know the mechanism for that, but sometimes the blood thinner warfarin is helpful. And then also anti-inflammatories like an indomethacin may be helpful as well, prophylactically. So once the ankylosis has occurred, once the bone formation has really matured, it really causes a lot of problems for patients in terms of their range of motion. And if you've tried the medications and you've sort of prophylactically tried to stop it and it still happened, surgery would be the next step and sort of final step. It's a very difficult, bloody surgery. So like I said, orthopedic surgeons are not really a fan of it. After they remove the excess bone, it's very likely to reoccur. So, you really only do surgery when it's kind of your last resort. If people are getting like chronic pressure ulcers, or there's a lot of pain related to it, or loss of function, then surgery may consider sort of going in there and removing some of that bone. But they usually wait until the bone formation is matured, which may be 6 to 18 months after the original injury.